I'm Kathy Olewski, the host of the Road to Wellness educational webinar series for the Vasculitis Foundation. I'm a patient like many of you living with vasculitis. I was diagnosed with ANCA-MPA in 2008, and I was in treatment for 6 years. I'm extremely grateful to have been in remission off treatment for 8 years. And I hope to help the Vasculitis Foundation bring awareness to this disease. Our webinar topic for today is pain management with vasculitis. And I'd like to begin by introducing our two speakers today. First of all, we have Dr. Tanaz Kermani, who is the founder and director of the Multidisciplinary Vasculitis Program at UCLA. She grew up in Mumbai and moved to the United States in 1996 to pursue higher education. Dr. Kermani trained at the Mayo Clinic in Minnesota, including a 2-year VCRC fellowship in vasculitis. She's been at the University of California at Los Angeles since 2012, where she specializes in vasculitis. And she's an active member in the vasculitis community and has ongoing research collaborations and several publications in large vessel vasculitis. We also have a patient with us today, Charlie Granger. He is a patient living with peripheral necrotizing vasculitis, which is an ex-ANCA vasculitis, since his diagnosis in 2019. He and his wife have owned a consulting company, Healthcare Strategies, for 25 years, but he's currently retired and living in Bedford County, Virginia. Well, I'd like to say welcome to both of you. I appreciate you. We all appreciate you being here today. And I think we'll begin today by turning it over to Dr. Kermani. I think you have some important information to share with us.
Okay, can everyone see? Okay, so what I thought we'd do in this talk is provide an overview of neuropathy and vasculitis, and then also discuss the diagnosis, evaluation, treatment, and then how we manage the pain, which is often a big issue in these forms of vasculitis that can affect the nerves in particular. So we'll start off with a case, actually a few cases that illustrate some of the different forms of vasculitis that can cause the same issues, especially when it comes to the nerves. So we have a 52-year-old woman who has this new rash that I'll show you a picture of on the next slide for 3 months. There are these tender, painful nodules. Previously, they've caused ulcers or opening in the skin. Also feeling unwell with a 10-pound weight loss, pain in the joints, especially the knees and ankles with swelling as well. No abdominal symptoms, and then starts to develop sharp shooting pain, first in the right arm, followed by weakness of the right wrist. So here's a picture of the rash. You can see this lacy rash, and there are also some nodules under the skin, which is deeper inflammation. And then a picture of the wrist drop, which is the one that has the right, with the white bandage, where they're unable to lift the wrist up because of the nerve being affected. So on our further evaluation, we noticed that she has anemia, she has an elevated white count, platelet count, which are all signs of inflammation, normal kidney and liver function, high markers of inflammation, and positive testing for hepatitis B. A skin biopsy was performed because there was an active rash that could give us a diagnosis, which did show vasculitis. And this was a diagnosis of polyarteritis nodosa. Here's another case, a 63-year-old woman with a history of hepatitis C that was untreated, who came in with 3 months of fevers, weight loss, decreased appetite, also with muscle aches, joint pain, and then numbness and tingling of the hands and feet, then started developing sharp shooting pain in the right foot, and then was starting to have severe color changes. So you can see a lot of dusky changes of the fingertips from lack of circulation. Testing here actually included normal blood counts, liver, kidney function, urine, high markers of inflammation, positive test called cryocrit, which is a protein that comes out in the cold and can cause vasculitis. And then these other markers called C3, C4, which are markers of immune activation that were low, suggesting activity. I told you she has a history of untreated hepatitis C, so there was a high viral load. And this was a case of cryoglobulonemic vasculitis. The blood tests were sufficient. We didn't have to do any biopsy. This is another case, a 45-year-old man with chronic sinus issues, nasal polyps, who then develops asthma, joint muscle pain, and then sharpshooting nerve pain that's moving around from the right foot to the left hand to the left foot in rapid progression. This person had a very high white count, most of which was eosinophils, normal kidney liver function, urine, and then high markers of inflammation and these ANCA tests that came back positive. These are one of our other markers for vasculitis. They had an EMG which confirmed something we call mononeuritis multiplex, which is involvement of multiple nerves related to vasculitis. And in this case, again, based on the blood tests and the EMG, we were able to make a diagnosis of what we now call EGPA, but used to be called Church-Strauss. And then the final case is a 55-year-old previously very healthy man who starts developing sharpshooting pain in the hands and the legs over several months without any other associated symptoms. So as opposed to the previous cases, there's no rashes, no muscle pain, no weight loss, no joint pain, and then starts developing weakness first of the right foot, which then progresses. And here, all of the blood tests, including tests for vasculitis, come back normal. EMG again shows this finding of mononeuritis multiplex, so involvement of multiple nerves in different distribution. And here we had to do a nerve biopsy because all of the blood tests were unrevealing, and this did show vasculitis. So this is a case of a form of vasculitis that's limited only to the nerves, called non-systemic, because again, you don't see any of the typical rashes and other features outside of the nerves in this form of vasculitis. The markers of inflammation are usually normal, but this is still a so-called organ-limited form of vasculitis that affects just the nerves. So when we're thinking about pain, we think about how pain is being processed in the brain and also along the different pathway. So I'll start you down on the right lower part of the figure where there's the skin. So over there we have these nerves. So there are these sensory nerves in the skin that then send signals into what's called the dorsal root ganglion, which then goes into the spinal cord. And then they travel up to the brain. And then there's also a response from the brain, which comes down the descending pathway. So there's multiple different levels at which pain is being processed. Similarly, when we think of the different types of pain, there's different categories. So there's what we call nociceptive pain, which is, if you stub your toe or if you have an injury, you get inflammation or in that local area from the trauma. And then that sends the signals up to the brain and you have a response. Then there's neuropathic pain, where the nerves that are sending the signals to the brain and the spinal cord can get affected, pardon me, either because of things like entrapment, where the nerve is trapped, or vasculitis, or metabolic issues, etc. And this pain is usually along the distribution of the nerve. And then there's something called centralized pain, and that's usually what we would say is very widespread pain that has to do with pain processing. So one of the key ones for these central pain syndromes would be a condition called fibromyalgia. So moving on to the anatomy of the nerve. So on the left bottom of the picture, you have a single nerve. So the axon is the so-called cable that sends all the information back and forth. And there's this coating called the myelin sheath, which protects the nerve. And then you have these groups of these bundles of nerve fibers, which are represented on the right lower portion. And then you actually have many of these nerves come together. And so that's the central picture. And what you can see are these blood vessels that are present in those large sheets or bundles of nerves. So you have the red and the blue representing the blood vessel, which gives the circulation to the nerves. And this is important because that's the part that gets affected in conditions like vasculitis. So neuropathy is a generic term indicating damage to the nerves, just like arthritis is joint pain. And there are many different causes. Probably some of the more common causes would be metabolic conditions like diabetes. Medications can cause neuropathy as well, especially some of the chemotherapy medications that are used to treat cancers. Then there are things like vitamin deficiencies, especially deficiencies in B12. You can have trauma to the nerve, alcohol abuse, infections, and then autoimmune diseases, and this includes vasculitis. So what's going on with vasculitis? So here's a picture. The top panel is a normal artery, and you can see its regular wall, and you can see that the blood would flow through very easily through that broad section of the artery. The middle panel is a narrowed artery where there's inflammation in the wall of the artery that causes the inside to start getting narrowed. So you can see that as opposed to that big plump artery where you can get a lot of circulation, now you're getting less blood flow. And then on the bottom panel is an extreme case where the artery gets completely blocked. So that's occluded. And those are the things that happen in vasculitis. And then it depends on what's happening at the other end of the artery. So if this is an artery that's supplying a nerve, for example, that would cause neuropathy and pain from there. If it's a big artery that's circulating, say, the arm or something, then you would lose circulation in the arm. So if it's going to a vital organ, then you would lose circulation to the organ. And there's many different sizes of blood vessels. So this can happen in the large blood vessels, the medium-sized blood vessels, or the small blood vessels as well. So back to our picture of the nerve. So these are actually small blood vessels that are in supplying the nerves. And these are the ones that get affected in the forms of vasculitis that cause neuropathy. And you can think of it as a stroke to the nerve because it just suddenly the blood supply is cut off and that nerve gets damaged because it loses circulation and the nutrients that come with it. So again, like I hinted, there are many different sizes of blood vessels, but the same process of inflammation in the blood vessels can cause all these different forms of vasculitis. So there's the large vessel vasculitis, there's the medium vessels and the small vessels. And when we're thinking of neuropathy, it's usually the medium to small sized blood vessels that get affected just because those are the ones that are supplying the nerves. So there are many different forms of vasculitis that can cause neuropathic pain. So we have things like ANCA vasculitis. There's 3 different forms, what used to be called Church-Strauss or EGPA. There's microscopic polyangiitis, which Kathy just told us about. And then there's also a different form of ANCA vasculitis called granulomatosis with polyangiitis, or what used to be called Wegener's. And depending on the form of vasculitis, you can see 20 to 65% of people with this form of vasculitis can get nerve involvement. The highest is with the patients who have EGPA or Church-Strauss, like that 3rd case that I presented. Then there's polyarteritis nodosa, which is a form of medium vessel vasculitis. There again, a significant proportion of people can have involvement of the nerves or vasculitic neuropathy. The cryoglobulonemic vasculitis, where that lady had lost circulation to the fingers, 65%. And then there are some of our rarer forms of vasculitis. There's a form called urticarial vasculitis, where people get hives. That can sometimes cause nerve involvement. Other autoimmune diseases like lupus, Sjogren's, rheumatoid arthritis can sometimes cause vasculitis as well. So those can also affect the nerve. And then what we talked about with the last case, the so-called non-systemic vasculitic neuropathy, where there is inflammation of the blood vessels supplying the nerves. And this is a form of vasculitis, but usually the only area that's affected are the nerves. You don't have any other signs either on blood tests or in speaking to the person to suggest what we call systemic vasculitis, the other forms that also affect other organs. So we label this a single organ form of vasculitis. So the symptoms, usually these things are abrupt in onset, rapidly progressive, and the areas that are affected. So the symptoms would depend on what areas are affected, whether it's the upper extremities or the lower extremities. Typically very painful, sharp shooting, burning pain. Some people also have associated numbness, tingling. And then if the motor nerves are involved, which are the parts that help with the movement or the strength, then weakness as well. And again, the typical distribution is in the hands and the feet, in the upper and lower extremities. So this is a schematic where it almost looks like a dart where you're just kind of hitting different nerves that are getting affected, involving the upper and lower extremities. And sometimes if it's been going on for long enough or hasn't been diagnosed for a while, it can just start looking like what we call something symmetric, where both sides are affected evenly, rather than this patchy, atypical, asymmetric distribution. So the first thing is evaluation. Our neurology colleagues are very important in diagnosing and evaluating vasculitic neuropathy, and also thinking about other causes that may look like vasculitis that are not vasculitis. The blood tests and laboratory evaluation are important. Those are typically done by rheumatology. We may think about imaging if there's suspicion that there's something else, like back issues or disc disease, which is more common. Sometimes if it's involving the nerves in the face, we might need things like MRI of the brain. One of the diagnostic tests that we have is the EMG. So we'll talk about that as well. And then we also have things like nerve biopsy and muscle biopsy that may help with the diagnosis. So it's usually a combination of things. So for blood tests, we always want to assess the organs. So blood counts, liver, kidney, sugar, urine tests. And then there are these markers of inflammation. They're non-specific, called sedimentation rate and C-reactive protein. They just tell us if there's something going on. They cannot actually give us the diagnosis. We think about chronic infections like hepatitis B, hepatitis C, HIV, which can cause certain forms of vasculitis. And then we have all of our autoimmune markers to see what form of vasculitis it is. And this includes things like the rheumatoid factor, assessing the immune system called C3, C4, cryoglobulins, which are these proteins that precipitate out in the cold. Again, that was the second case. And then we have these ANCA markers. And then again, if there's someone who sounds like they have an other autoimmune disease like lupus, rheumatoid arthritis, Sjogren's, we would do testing for those as well. So the EMG test is one that's done by our colleagues in neurology. It can evaluate the muscles and the nerves. It measures the electric signals and the health of those electric signals. And it's very helpful in localizing what's affected. Is it the nerve that's affected? Is it the muscle? How extensive is the involvement? And then also it can give us information on what we call the level where the nerve is involved. So is this coming from the spinal cord or is it further out in the periphery? And it also is a useful modality sometimes to follow over time. It can be painful. It's not something that we routinely recommend following over time, but it can give us information in someone who has vasculitis, for example, and is having new symptoms to reassess what's going on. Then there's the nerve biopsy. Now, this is not always indicated. Like I showed you, there were cases where we made the diagnosis of vasculitis based on the clinical features and the blood tests that we had. But in cases where it's unclear, biopsy can be helpful. It's also not always a nerve biopsy that we need. For example, sometimes if there's rashes or other areas that are affected, like the kidney, we may go to biopsy those organs. And then if that shows vasculitis, we have a diagnosis. It would be needed for the non-systemic form because otherwise we have no way of making that diagnosis. Usually they'll take a nerve from the lower extremity, one that's not affecting the movement of the muscles, so a sensory nerve. And then there are studies showing that when you do a muscle biopsy as well as the nerve biopsy, that may actually increase the yield of the biopsy. Side effects, of course, are pain. And then you also have, in some cases, poor healing, infection risk from an open wound, especially because if this is vasculitis, oftentimes we then have to put people on immune suppressing medicines that can increase risk of both infection and poor healing. But these are not very common, especially if you have somebody who is an expert and who is doing this routinely. So usually a neuromuscular specialist is what you want. So this biopsy, the center is these circles where there's actually the blood vessels, and you see all those blue dots around them, and that's an intense inflammatory infiltrate and inflammation all around the vessel wall that just shouldn't be there in a normal tissue. So that's what we usually will see in a biopsy. For the treatment, so the most important thing, and I think one of the hardest things and messages to deliver as a physician to someone who has vasculitic neuropathy, is that our treatment is to stabilize what's there and prevent more damage from occurring. So unfortunately, it will not reverse things that have already occurred, and that can be very difficult for both the physician to deliver, but also the patients who are dealing with the symptoms. The immunosuppression that we use depends on what form of vasculitis is diagnosed. And then also important, if there is an underlying cause like infections like hepatitis C or hepatitis B that are driving the vasculitis, treatment of the infection is also important. Pain management, physical occupational therapy, fall prevention, including use of braces, et cetera, are also an important part of the treatment. So coming to the immunosuppression part, which is usually done with the rheumatologist, it starts out with high dose steroids, usually for severe manifestations like the nerves. We would use high doses of IV steroids, typically given over 3 days, followed by high doses of oral prednisone. Then there's the so-called chemotherapy that we use for what we call induction of remission, so to put people's disease into remission. And there's two main ones. There's cyclophosphamide, and then there's another treatment called rituximab. Again, the treatment may depend upon the severity and also the form of vasculitis. Some forms of vasculitis, like somebody who has a really high cryocrit, like that person with the purple dusky fingers, we might do things like plasma exchange to get out some of those circulating proteins that may help with the vasculitis, but that would only be a temporary measure. In some of the cases where some of these things are not working, we might add IVIG. So that's another form of treatment. It's not the first line, but it is one of the treatments we use for vasculitis, especially neuropathy from vasculitis. And then there's a whole host of other immune suppressing medicines. Sometimes those are used after we do the initial chemotherapy and treatment. So what about treating the pain? Again, this is a very painful condition from speaking to our patients who have experienced this. So for the acute pain, we have medicines, tramadol, which is one of our pain medications. There's opioid medications, lidoderm patches, topicals like capsaicin. Again, some of these things may be helpful for acute pain. For acute pain, it is appropriate to consider opioid therapy. For the long-term pain management, usually we would like to consider other options. So there's gabapentin or Lyrica that work at the nerve level to help with decreasing the pain and the intensity of pain. And then we have other medicines that are in the antidepressant category, but they regulate some of these chemicals like serotonin that are made in the brain and can also offer pain relief. Most of the time, we would recommend evaluation with a pain management specialist as well to come up with a treatment plan. What about other treatments? So there are supplements. Most of these studies are from people who have neuropathy from diabetes. Some of them are from studies from chemotherapy-induced neuropathy. So again, different from vasculitis. There's supplements like alpha lipoic acid that may be beneficial. There's something called low-level laser therapy. Again, that's from diabetes. There's medicines like low-dose naltrexone, which we've used in patients more with fibromyalgia and some other pain syndromes as well. Again, not very good data for most of these things. And then CBD, there's been a lot of interest in as well. Again, we just don't have a lot of good data for any of these, for neuropathy from any of these causes, let alone vasculitis. And then it's also important to address mood and sleep, because all of these things will play into the pain and pain processing as well. So I found a link. There's a foundation for peripheral neuropathy. The link is over there. And they had links and information on other modalities as well that may be helpful in managing pain. There's things like acupuncture, biofeedback, mindfulness therapy, some of these other treatments as well that might be helpful for long-term management of pain. Again, initially it's important to treat the acute issues that are going on with the vasculitis, and then consider some of these options at a later stage. So the prognosis, again, like I hinted, there usually is improvement, but not resolution. Again, some of these things are related to damage to the nerve from the lack of circulation, and these damaged nerves are slow to heal, and usually it will take months to a year or longer, but most of the time there will be gradual improvement over time. Again, from our standpoint, it's important to make sure that the inflammation and the vasculitis is well managed so that we're not having new areas getting affected. We do recommend physical therapy, occupational therapy to work on the strength, usually once the pain has improved and the inflammation is controlled. So in summary, as you saw, nerve involvement is common in many different forms of vasculitis. All of them are the medium to small vessels. Isolated nerve involvement can also occur. Our treatment is multimodal. So there's the management of the vasculitis, management of pain, physical therapy, occupational therapy, some of the other modalities. And recovery, unfortunately, is a slow process. And again, the goal of therapy is to prevent progression so that we're not having new areas that are getting affected. And with that, I thank you for your attention.